Today is our opioid forum here at Mobile, Mid-Ohio Board for Independent Living Environment. It's an attempt to show how the opioid crisis in our community is affecting people with disabilities, as addicts as well as recipients of opioids because of excessive pain.
I'm here at the conference because I wanted to assist Dr. Christian in putting on this conference for the opioid and the disadvantages of the African American community in relationship to this drug. And also as a consultant, I thought it might be helpful to him in helping him identify some of his opportunities and some of the agencies he has. And we're putting a number of different proposals together to try to reach out for some additional funding to do that.
Well, it's a conference to inform people, and so through the conference as well as this video, we'll be attempting to let folk know how folk become addicted with street drugs, as well as how people who are taking medications become addicted and how that will affect the outcome of their lives.
People who get high, they get high because they want to get high. I was a dope fiend. So there's not a whole lot you can tell me about being a dope fiend. And I started out being a dope fiend in 1956. I was in the sixth grade. 1959, I was in getting ready to graduate. In 61, I was on the move. See, so I shot dope, used dope, because that's what I like to do. Say, and when I talk to people, I don't care. People do what they like to do. Yeah, and it's a big problem. And it's a moral problem. It really is a moral problem.
I think it's the pain pills, but also I don't want to use the word like conspiracy, but you know, the pharmaceutical industry is pumping it up, and doctors are pumping it up, and the oxycodone and other kind of formative drugs like that, it's easy to get those drugs, and your doctor will prescribe them for a number of years maybe. But after that, they'll take you off of it, and then you'll try to find other kind of alternatives like Percocets. And then when that doesn't last or work, then you progress on to heroin, and and certain deaths.
When I returned from Vietnam, okay, soldiers, so forth and so on, and I really was looking at the scourge that was in the community. Now, that wasn't affecting me from that perspective because I was looking at it sideways. No, the more I stood, in the community, the more I looked at, basically, like Marvin Gaye, things are still the same, still the same, But in that, I was incarcerated. And while I was incarcerated, I was a reader before, but I read a lot. I read a whole lot. I mean, really. I think, and then I decided when I got out the penitentiary is that I wanted to be like my father. So I wanted to be a husband and a father and raise a family. And I became Muslim because I didn't see any way personally for me to do that. And so I became Muslim. When I became Muslim, then that was in 1976. And from 1976 until now, by God's permission, the most addictive thing that I do is sugar, which is also a scourge. Yeah.
Knowledge about this. I worked in various drug programs in the past, and I've watched the evolution of the opioids coming into existence before and as it exists today. And also I'm concerned about the fact that more and more African Americans are falling prey to it. And I think that's necessary for them to realize that just because you're a patient, that you're also getting ready to be a drug addict. And a lot of times they don't really realize, they think they're just a patient, but in the end, you'll end up a drug addict. And a lot of times people progressing on to heroin and other kind of street drugs.
Well, one of the things that we do here at the Mid-Ohio Board for Independent Living is that we are information and referral agency. And so if someone would simply call our main number, 614-443-5936, we will be able to put them in contact with some of the agencies that will be represented here today, such as Southeast Mental Health Agency and we'll put them in touch with some of the counselors that will be on our panel today. We're especially grateful for the ADAMH Board of Franklin County, Dr. Kevin Dixon, and also to the Franklin County Deaf and Hearing Program for their contributions to our agency, which make it possible to do forums such as these.
All right, I'd like to welcome everyone today. On my far left, we have Mr. Sumi Islam.
Yes.
Islam. Mr. Islam is a prison reform advocate. He is the state Elam for several institutions. Am I saying that correctly?
Certainly.
Okay. He's the national consultant of prison reform spokesman. Mr. Islam counsels young men as to how to get off of drugs and become productive citizens and live their lives and live a better life. Also, on our panel that we have here today, we have Michelle McGuire, who is a clinical pharmacist for Southeast Healthcare Services. And Michelle is board certified care pharmacist for Southeast Healthcare Services, is a community mental health for Community Mental Health Center and an Addiction Treatment Center with embedded federally qualified health center, FQHC. She works within the FQHC to provide medication therapy management, disease state management, and harm reduction services for patients with serious mental illness and addiction. Is that good? Okay. And we're going to go ahead and start our discussion with the panel that we have. I'm going to ask Mr. Islam to just give us some background and tell us exactly what we're trying to accomplish today, please.
As I was mentioning in the interview, in 1956, I was in the 6th grade. In 1959, I was getting ready to graduate from senior high school. Yes, 59. Yeah, I guess it was. I don't forget. You know, you get a little, yeah, ain't a big problem. But anyway, my involvement with drugs started absolutely in 1961. And what I say to people all the time about drugs is that people do things because they want to do them. And it's unfortunate. I mean, it's unfortunate. And what I found in my life all the way up to here is that there's a very selfish type situation in it. Selfish meaning there's no concern about family members, there's no concern about the house, the car, or so forth and so on. And it really boils down to there's no concern about the individual, he or she, where it goes. It's suicidal. And that is a conception that I've grown with for the longest. In America, maybe I say that in America from that perspective, what is being presented to the people is a medical model. You know, in other words, it relieves that person from all responsibility of using drugs, right? And I've said since I can remember, you catch a cold, but you take a drink. So you have a choice as a human being, to do what it is that you want to do. And if you choose evil over good, that's your choice. That's your choice. Now, the job of people in the community is to try very hard to bring those individuals back and redevelop their family life and redevelop them as individuals, you say. I'm a firm believer. People talk about symptoms. Well, they talk about symptoms in the sense of whatever, whatever, right? And then, but when the rubber hits the road, what it really is, they never really address the problem. And as far as I'm concerned, the problem is people have lost sight of God. Period. Okay, because if you're, I'm not a religious type person like people will, you know, I'm not a preacher. I'm an imam, you know, I'm a husband, and I'm a father, I'm a grandfather, and I'm a great grandfather, you say. So I look at things from the perspective of development, okay? So when I counsel young men, okay, it goes all the way back to like Children's Hospital. It goes way, you know, I mean, by God's permission, I've been involved in this type of development for a long time. And when I counsel, I ask them, why is it that you do what you do? And 9.5, the answer is, I don't know. That's the answer. You know, and you could be in a counseling in Southeast, wherever it is, and you ask people, so well, why do you do this? And they'll say, I don't know. I don't know why I do it. So it has been, I guess, my lot in life, however you want to, is to try to find some clarity with the individual, okay, so that they can take the responsibility of correcting their own lives. Because as long as, there was a, Thomas Side was a psychologist. A lot of people didn't like Thomas Side. And Thomas Side said there's no such thing as mental illness. Unless it was organic, okay? He said because like in America, you know that you're going to be taken care of. So a lot of times it's just plain laziness. You know, it's plain laziness. You know, I can knock on the door here and get assistance, go to Southeast and get assistance, go to Mary Haven and get assistance, and so forth and so on. You know, people have to take charge of their lives. I believe that. I believe it totally. I'm gonna close with this. When I was in the streets, and be thankful that I'm not in the streets. I'm serious. You know, my mother used to tell me about my brother and I all the time, you know, you're like racehorses. She said, you're gonna wake up one day and find yourself dead. So just out of habit, I read the obituary every morning and see if my name is in it. That's a joke. Please take it as a joke.
So welcome, Attorney Potts.
Thanks for having me.
I'm going to ask Michelle to give us her perspective on the opioid crisis, if you will, please.
Thank you. I'm a pharmacist, so I can talk specifically a little bit about how the crisis started with prescription drugs. We all know they started with prescription drugs. Between 2000 and 2015, the number of prescription opiate painkillers that were dispensed and prescribed by doctors and given by pharmacists increased by 4 times. So just in that 15-year period, we had a huge wave of really high-powered addictive opiate painkillers. Now, it's questionable whether the amount of pain really increased during that time. More than likely it did not. It started certainly with it was a perfect storm really. So, you know, in medical school, prescribers are not given a lot of education on addiction. Working with a lot of primary care and family medicine doctors, they're just not. They don't know, they weren't trained how to screen for it. They didn't know how to prevent people getting addicted. And then, honestly, we need more pain medicine options. So they felt helpless. So someone comes into the primary care office, they're in pain. Doctors generally go into medicine because they want to help people. They don't want people to suffer. They want to treat their pain. They, give them ibuprofen or over-the-counter Tylenol. That doesn't work. There aren't many other options for patients. So the drug company that made OxyContin was a perfect solution to that. They came and said, treat your patient's pain with this oxycodone or Oxycontin. It's not addictive. They, really downplayed the addictive nature of it. And so there was also one really well-renowned journal called the New England Journal of Medicine that published a letter from a doctor that was well-renowned, and it said, these medicines are not addictive. And back then, we didn't have the internet as widely, so everyone kept citing the same small letter. Come to find out, it was just a study that was done with 30 patients in a hospital, and so that just continued to get cited by the OxyContin manufacturers, saying these medicines are not addictive. And so then it just exploded from there. A lot of doctors also saw the money in it. They opened up pill mills. Portsmouth, Ohio is one of the leading areas of pill mills in addition to Florida. So Portsmouth had these doctors that would just write prescriptions all day, every day, maybe without even seeing the patient, or maybe just seeing them for 30 seconds, saying, are you in pain? Is this oxycodone working for you? And then just prescribing it, huge quantities. So people were getting addicted to it. But to be fair, people also had legitimate pain. So people, maybe we were talking about a little bit earlier, is that, you are in pain. This medicine helps you. It does help your pain. It's prescribed by a doctor. It's given to you by a pharmacist. So you start taking it, and it does relieve your pain. A natural part of opiates, though, is that you need more. Your body gets used to the pain-killing effects. You always need more. That's a normal part of pain management. That doesn't mean you're an addict. It's just your body gets used to these drugs. So people needed more and more quantities of them. They also trigger addictive potential in a lot of patients. So people become addicted. And then, I said in the beginning, between 1990 and 2015, we had a quadrupling of prescription painkillers. We also had a quadrupling of overdose deaths. So people also overdosed and died on these drugs. And then we started noticing, and so now, around the country, we've done a lot to prevent these prescription painkillers from being prescribed. What happened with that, though, is that everyone got cut off of their painkillers, and like I just said, you can't just stop taking these medicines. You are physically dependent on them. If you've ever seen anyone be in withdrawal from an opiate, have you ever seen that? Dope sickness? I mean, it's the worst feeling in the world. You feel like you want to die. It's like having the flu times 100. That's what most patients tell me. So then, of course, what was on the street and ready and cheap and available was heroin. So that's how people get cut off their painkillers. They can't get the painkillers. There's not pain management doctors around. I mean, to get into pain management, it's a long waiting list. So people started on heroin, and that was really then, we even had a huge other surge of the opiate crisis. And then fentanyl came. And that was another huge, doubling of overdose deaths. And now fentanyl, some people are going to that as their drug of choice. So some people tell me that they do a gram a day of fentanyl, which is an insane amount of fentanyl. That's 100 times stronger than morphine. I mean, that's just a lot of fentanyl. And then another new concerning thing is that now fentanyl is being laced into cocaine and methamphetamine. So other drug users are now getting addicted to opiates, so it's sort of moving into other populations as well. So we still have a long way to go, but we do have, a lot of evidence-based things out there. Number one is Narcan, so that has reduced a lot of overdose deaths in the last year. This was the first year in I want to say 20 years that we've had a reduction in overdose deaths instead of just increasing. So actually, a lot of it is because Narcan, which is the rescue medicine that is in every, ED and EMS, and now people can have it at home. If you go to our pharmacy downtown, you can get a prescription for Narcan, and you can save anyone that you think is overdosing. So that's one thing. The other thing is doctors are being more educated now that they see all their patients are dying. I mean, at Southeast, I think for a while there, it felt like every month we lost a patient every month from an overdose death. So now we're trying to be more educated about not giving out too many prescriptions in the first place, and also trying to slow down and understand that there's different types of pain, and opiates do help with all types of pain, but if you have nerve pain, there's other medicines that might actually help that are not addictive and are not as addictive, and they're not opiates and can't make you overdose as easily or become addicted to them. And then if it's other things like more of a physical problem, that you can do something like physical therapy, or if there's acupuncture, or even just a lot of chronic pain. There's actually been a lot of research with like counseling, so CBT, and making it more of a, dealing with the pain and taking other non-addictive options. And then certainly to get people off of painkillers, we have, Suboxone, methadone, and naltrexone as well. But it is a problem of not having enough other pain options. If you're in pain, you do need something to help your pain. So there's a lot of good research coming out of the government, but it's 5 years down the road before we have new drugs out there. So that's my.
Michelle, how does one identify whether they're taking the pills simply for medication, or whether it's become actually an addictive type drug? You know what I'm saying? In other words, perhaps the prescription calls for 3 pills a day, and you find yourself taking 5 pills a day or something like that. How does that work?
That's probably the hardest thing with opiates, because like I said, your body gets used to the pain-killing effects. They wear off sooner. You start with 2 or 3 pills a day. That's your prescription. But you find that in the middle of those pills, you feel like you still have breakthrough pain. So it's a slippery slope between, if you go to your doctor and they increase it in collaboration with you and you're doing it the right way, that would be more appropriate use. But then if you're starting to take extra, running out early, and then other things happen, signs of addiction are lying, manipulating, stealing things. When the signs of addiction start happening, that's when it really gets concerning. But go ahead, question.
When a person comes to you and he's been taking 3 to 4 to 5 pills for his pain, what is his options? What is his options that he can go to be able to get off that medication?
Yeah.
To probably start a new medication that won't have him taking 3, 5, 4 pills a day.
Right. Well, at our clinic with our primary care doctors, before we send them to pain management, first of all, these medicines, I'm a firm believer that most primary care doctors don't have the basic knowledge of managing these medicines. Some of them do. Some of them are well versed in that, but really we try to send them to a pain management specialist, because there's so many other options that they can do, like spinal injections. There's other like lidocaine patches. There's other alternative medicines like ibuprofen or things like that. Again, I'm big on like acupuncture, physical therapy. So other alternatives that isn't just increasing the dose of the opiate. And the other reason that I say about primary care is that primary care doctors really get 5 minutes with their patients. It's set up, our medical system is set up for them to just increase the dose and move on to the next patient. They're on a conveyor belt. So pain management doctors tend to have more time and more resources in their clinic to really dig into what's going on. Exactly.
And for people who don't have insurance, it's totally impossible to get it.
That's exactly true. I mean, we are lucky in Ohio to have Medicaid expansion and to have options for insurance that most states don't. I mean, I think it's, again, like a national conversation about we need to expand all these options. We also need to incentivize doctors to go into pain management specialties, because we need more pain management doctors. We do have a huge issue.
The number of clients that we see here that come through our doors don't have, even with Medicaid expansion, a lot of them are left out.
Right.
And so if they've been cut off from their only source of pain management, the alternatives are very limited.
Right. Yeah, it's a huge challenge. And I mean, we're lucky, again, we have federally qualified health centers that you can pay on a sliding scale, but that's not always an option for everyone. I think working with agencies like yours to get referrals to places, somewhere like where we are set up, a federally qualified health center generally does have more time with our patients. Like, we get more than 5 minutes. We get 20 minutes. We have a doctor that does, we have a physical therapist on staff. We have acupuncture. We have osteopathic manipulation therapy. So some of those options, and our doctors do try. We also do prescribe Suboxone, which Suboxone is used both for opiate addiction, but it does help with pain. So that's a little of a safer option.
But is that not addictive as well?
It can be addictive, but it's pretty under a controlled environment. So some people believe it's a transfer of addictions. A lot of people do. The medical model, which is what I ascribe to, is that your brain, if you become addicted or you take these medicines, it's a change in your brain. Your brain chemistry changes, and so some people may think that without opiates, for a person that's truly addictive with those true addictive behaviors, they may never be able to function without some sort of medicine to assist.
What would you say to a person that has a mental illness and has a drug addiction at the same time?
Treat both. That's what I say. Get into a psychiatrist, get into a counselor, get into a good primary care doctor or a pain management doctor that can help with all of those. Because you have to treat. I think you have to use our medical specialists that are there. But I think what you were touching on though is really important too with addiction. We can't just say it's all medicine and counseling. It is about rebuilding your life and having a family support, having a purpose in life, and it can't just be all about going to doctors.
I was in court and couldn't get away. I've handled multiple pill mill cases. Pill mill cases are cases that you have pharmacists and doctors writing prescriptions to people, and they get the drugs and then they sell the drugs in the community. They just write script after script after script, and they do it, and they have the case, the major case that I had, federal case. It was people that were going to Florida, they were going to Pennsylvania, they were going to Missouri, they were going all over the country. He would send different individuals to fill these prescriptions, and these doctors would fill them really unmonitored. They would just write them and write them and write them, and then they would come back and they would sell the drugs to do that. Most of these people were addicted, and they took advantage of their addiction. I'm the president of the Columbus Kappa Foundation, and we have a fraternity house over at on Mount Vernon Avenue, right in the heart of our community, which is changing. It's being gentrified, but it's really changing. But we have a program that is the opiate crisis in the African American community. Because how many of you know we've had this crisis in our community for years, right on 20th and Mount Vernon Avenue? Now it's a crisis because white people have gotten involved in this. Now it's a crisis. But we've had this demon in our community for years, right there on Mount Vernon Avenue. And you can't tell me they didn't know that they're selling dope and getting high right there on Mount Vernon Avenue. What our goal is from the Columbus Kappa Foundation is to make sure that the black community is not overlooked with these resources that they have. They have millions of dollars in resources now. This is a big thing going on now that now, because it's crossed over into the majority community, now they're pumping and funneling money in here for this now opiate crisis. And we want to be on the, we don't want to be left out as our community, and be vocal in our community and make sure resources of our community gets into our community. What we do is we send out community connectors. We have 3 community connectors, and they are like boots on the ground. They go out and they talk to people out there. Now, a lot of these people, I'm a recovering addict. I've been clean for 27 years. I had a $500 a day cocaine habit, crack cocaine habit, and it ruins your whole family. And there's a lot of reasons, social determinants, that make us go out here and use drugs and do that kind of stuff. It's no excuse. It's in our community, though. So I'm not looking at it from a theoretical viewpoint. I'm a recovering addict. I know that fiend mentality that you have when you go and you try to do anything to get money to feed that habit. So what we have is we have 3 community connectors. And we have a targeted area in the Near East Side, a little bit of the North End, a little bit of the South Side, And what we do is we send them out, and they talk to people, and what they do is they're a resource to these individuals that are out on the street, because a lot of us don't trust treatment centers to come in and go in, and we think that you're going to turn us in and go to jail and do all that. We don't. There's a trust factor in our community about some of these treatment centers and all that. So what we do, we try to bridge that gap to give them information. We're trained in Suboxone. Not Suboxone, but Narcan training. We just had another training to do that, because that is it will save your life. And it's not prescribed. You can get it and you can use it without any training, which I was surprised to know that they give you, you can get Narcan to administer to people. And a lot of these drug houses, they have Narcan there just to help if somebody ODs or something in the drug house. We have, and you were asking about the medication and taking the prescribed medication, and when it's a progressive illness, meaning that you'll start with a little, and then that monster just grows and grows and grows and grows. And a lot of these doctors I see are not trained on natural remedies, like you're talking about acupuncture and other resources. It's kind of like, to me, they're in cahoots with the drug companies. Now, I know that they monitor that, because a lot of these, my fraternity brothers used to be pharmaceutical reps. And what they used to tell me, and I don't think they're allowed to do it anymore, but the doctors would, they would give doctors benefits for using their medication and prescribing their medication. They would give them all kinds of stuff to influence them to prescribe their medication. I don't think they're allowed to do that now. They can't do these kind of things, but you know, if there's a will, there's a way. And I don't think they teach these doctors the natural remedies that they need to be taught. They're unequipped, especially like you said, a family practitioner. They don't know any thing about that, and they're not. To me, they're not equipped to do that. We see a lot of them don't even have Medicaid. A lot of people that we've run into, that they don't even know how to. Again, they might be eligible for it, Medicaid or Medicare. They don't even have that, so they can't get in treatment programs a lot of times. And the few treatment programs you could get into without insurance, the line is so that we've taken people. Here's an example. We've taken people to a treatment center, and they said, we don't have any beds available. You have to wait to wait your turn in line to get into the treatment center. So what do you think that addict is going to do? You think that addict is going to, now when you're tired of using, you say enough is enough is enough. But when you don't get the help that you need, and they tell you there's a waiting list and you can't get in, what do you think that addict is going to wait? What are they going to do? And it's so physically addictive to them. They got to go back right back out there. So that's one of the challenges that we are fighting for. We have relationships with these treatment centers here, and we are fighting for the people in our community to have access, those that don't have insurance, to go we walk you to, we physically drive you. If you want to go in, we take you to the treatment center, then we advocate for them to let you in the treatment centers. And what we're doing in our Community Connectors program is to develop relationships with these treatment centers where they'll guarantee beds to people in our community. Because it's a problem. And then this fentanyl that's going on now. that you have fentanyl in cocaine. There even some people are saying they're even lacing it in marijuana to the point of, and you're talking about a lot of these people don't even know the power. And then there's, what is this, can fentanyl, the
Car fentanyl.
car fentanyl, and that is way worse than the fentanyl that's an animal tranquilizer, and it's killing people. It's killing people. Last month we walked down it's Taylor Avenue, because that's one of our areas. There was a man OD laid out on the ground right there in our community, right there, right around between Long Street and Mount Vernon Avenue, right on Taylor Avenue. He had OD'd and just put him out. He's right there laying on the ground. And we have a crisis in our community, so don't let it be known that we have not had this problem in our community, and we need to fight for the resources in our community.
Amen.
Yes, sir.
Okay, there's many people living in the shadows about their addiction and don't want to get help from any type of treatment. They either go back to jail, stay in the jail, do their little dirty work in jail, come back out, still do the same thing. Now, the resources that we got here in Columbus is better than any other community or state as what I have thought. Like North Central is the mental health place, Southeast, and there's people in there that, as you were saying, sell their medication. And we got loss of communication with those type of people because of their drug addiction and their mental health. Some people have schizophrenia and believe that they can hear voices, see things out there on ordinary, paranoia and all this type of stuff, and still be able to go back out there and still take that drug and still use it and find no type of help. And they go on a cycle each and every single day.
We've experienced that too, and one of when Columbus area was closed, and how it left a lot of people out there that were not getting help. I think they're getting more and more people into getting services now, but at the time when it shut down, it was a real problem. And when you have that dual diagnosis, it's a challenge, and because a lot of the individuals, if they're not doing it themselves.
And after that happened, I got strongly involved in wanting to help with this thing that's going on with all this heroin and fentanyl. And Brother Brady and I had talked about, let's open up a drop-in center for addicts that have no Medicare, Medicaid, want to get help, let people know that there is a place to come to and have it open 24 hours a day. And then, but we need a place for that bed to be open so that individual can, if he wants help then, because we know right then when you say y'all want help, they want to go now. So
Right now.
it has to, we're looking for dollars for that. We're going to just give me a building, give me some cots, fund it, and we can make it happen. That's what we would like to see happen.
Has anyone heard of the REACT team, like Southeast REACT team? Because they can, if you call them, they have people that 24 hours can go and bring people in to like the Maryhaven Detox Center. So they have a program with the ADAMH board that they have beds.
That's similar
for,
to what
so similar to that, but
the Columbus Kappa Foundation Community Connectors. But you call, there's numbers that you can call. It's 24 hours, and they take you to the.
Joined on the panel by
Thank you.
by Dr. Ortez, our Franklin County coroner, and I'd like to hear from her as from maybe from a statistical standpoint as to how this academic is really affecting folks.
Hello, so I'm Dr. Anahi Ortiz. I've been coroner here since 2014. Worked on, really it's an addiction crisis, right? Since 2015 through the coroner's office. And we do try and send out quarterly updates as to, how many people have succumbed, to death from addiction. And I'll share with you some of that. And I think some of what I wanted to do when I became coroner was not only be a little more transparent with statistics, but also look at trends and kind of go out into the community and talk about the trends that we're seeing, so that programs can use these statistics, can look at these trends to develop more programs and more pretty much solutions to what's going on. And I think right now what we're seeing is, one, it's the folks who are dying of overdoses are not decreasing this year. And actually, I'm going to estimate about a 10% increase from last year, unless something changes, right? So
I'm sorry, I maybe I misspoke earlier, because I thought, did last year it decrease from the year before?
Last year was the same.
It was the same, okay.
As the year before, and this year is going to be probably 10% increase from the year before. But and one of the biggest things that we're seeing, one, most of it is related to fentanyl, and you know that it's like 80% of the cases are fentanyl related, and most of them are what we call polysubstance. So it's not just fentanyl, it's fentanyl. We're hardly seeing heroin anymore, hardly any more heroin, but we are seeing, we're still seeing the pills, oxy. We're seeing more and more cocaine and more methamphetamine. So it's the combinations.
Are they laced with fentanyl?
Yeah, combinations of cocaine. So some people know their cocaine is laced with fentanyl. Some people don't know. Some people know their methamphetamine is laced with, and they're called speedballs when they know, right? But when they don't know.
Right. They have this fentanyl strips, and that's another thing that they have, which a fentanyl strip is that you can test your drug to see if it has fentanyl in it.
Wow.
That what she's talking about, the unknown.
Right. So if you're not looking for the fentanyl, you should be testing your supply.
Right. You can do that, and they're free.
Right.
We can give them out to you. They're free.
So those are some of the changes that's going on, but some of the other changes I'm seeing is in the population. So it's always been the majority of the white Caucasian population that have been dying, but slowly, and no one's really looking at this, but I've been tracking it, slowly it's gone from African American dying of overdoses, started out at, I think it was 16-17% back in 2015, 2016. And now I after Ms. Boyce called me this morning, I checked it till May of this year. For this year alone, 25% of those who have died of overdoses from January to May have been African American. So that's
What I say.
1 in 4, right, who have died of overdoses from January to May of 2019. And I'm going to tell you now that that is minimal, because unless something changes, it's going to be more than that. I recently sent an alert out for this past weekend. It was 9 folks died in less than 48 hours. It was around 36 hours. 9 folks died of overdoses. Of those 9, at least half were African American who died this weekend. And then we're seeing an increase in the Latino Hispanic that have gone up in terms of overdoses. It's not as high. It's 4% this year. Last year was 2%. I haven't looked at the age bracket, but just anecdotally looking through, it's been about the same. I'm going to say the 30s and the 40s are the most common who die of overdoses. The other trend that I've been kind of trying to get, folks who have money interested in doing something about is suicide. So the number of suicides is actually down this year from last year. However, where is it? However, the number of African Americans who are dying of suicide has doubled, right? So we have January to May of 2019, out of 66 folks who died of suicide, 13 were African American, which is about a 20% of the population who died of suicide. Last year, it was 10%. And I'm seeing it all the time when they come in. Many are related to their addiction. So this year, we're seeing kind of a secondary effect of that addiction in terms of suicide. They can't, what you hear all the time is they can't beat it. They can't beat it. They can't beat it. I can't live this way. And so then they take their lives because they can't beat it. They can't get help. They can't, So we're seeing more of that this year. But again, what's striking to me is, it's a doubling of the rate of suicide, even though the amounts are lower in terms of suicide this year. The shift is in who is dying of suicide this year. It's higher in the African American population than it was last year, almost doubling. So I also do run a mortality, we call it fatality review. So we restarted it this year in July, and we look at, we poll a certain amount of folks who have died of overdoses, and there's a group that comes together from a diverse area. So law enforcement is there, treatment centers are there, medical board, pharmacy board, DEA, you name it, neck care, they're there. And we bring together the information on each particular case that they may have. And this is done to look for trends, to look for ways that the community can kind of step in, right? And so we did 10 cases in July, and what I ended up doing was kind of charting. So what did everyone have in common? How many of these folks, whatever. 10 out of the 10 had law enforcement involvement. Either they were in jail or they had gone through a court in some way. Either probation, it may have even been just court and probation. And then when we sat down and talked about it, it turns out we have these specialty drug courts. There's not a lot of them, right? They only take a few, so many. But where most of the folks are being seen is the Court of Appeals. Now, I'm not a legal person at all, so I have no idea what some of the differences are in the courts. But it turns out that the woman from the Court of Appeals was there, the one who helps to run it. And what she's saying is that drug courts get assistance. So they'll have social workers there that work with the people that are going to drug court to get them hooked up with insurance, treatment, blah, blah, blah. The Court of Appeals has nothing. And the majority are going through that. But they don't have a social worker. They don't have people there that can assist these folks with just the basics like homes, finding a place to live,
Can I
food,
explain?
insurance.
The Court of Appeals is a higher court. So let me show you the courts that you have. You have the Franklin County, here in Franklin County. You have Franklin County Municipal Court, who has a drug program and a mental health program, which are very good. They do good work, but there's only a few places that they can get in. Then you have Franklin County Common Pleas Court, which handles felonies. Municipal court handles misdemeanors. So, and then you have a drug court who, Judge McIntosh is over, Judge Tyack in the municipal court, and Judge Thomas and the mental health court also. There's good programs, but they can only do so much. You have to understand that Franklin County is the largest and the most busiest courts
Yeah.
in the state of Ohio.